Thank you for joining me for a presentation on the proper logging document provided by the Council on Podiatric Medical Education. This is part 2 in a series designed to assist residents and directors to achieve success in logging. The new guidelines are effective July 1st, 2023. I am Dr. Danae Lowell, the COTH Region 4 representative and VA Site Director for Mercy Health Regional Medical Center here in Ohio. Part 1 included an overview of logging in PRR and the CPME 320 document. Part 2 is a review of the proper logging document, which is available to help understand accurate logging of cases in Podiatry Residency Resource. We'll start with some general guidelines and then get into MAV categories and subsections with detailed do's and don'ts of logging. Some examples will be discussed along the way as well as at the end. The proper logging guide can be found at the CPME website at www.cpme.org. Proper logging is a crucial part of every residency program. Residents play a huge role in logging success. Those programs with great attention to detail and education on proper logging result in very few errors. Programs with lesser attention to detail and education tend to continue bad habits year after year. When programs have on-site evaluations or request increases in positions, logs are reviewed in great detail and can help in achieving success, lead to potential areas of noncompliance, or result in denial of an increase when errors are evident. To find the online version of the proper logging document, go to the CPME homepage. There is a tab for residencies and a section on logging guidance. There are resources on the next page for guidance on logging wound care cases, the logging guide itself, and a slide deck. At the beginning of the document, you'll find some general guidelines. Ultimately, it is the responsibility of the program director to review logs for accuracy prior to verification. Within each category, there is a subcategory that starts out with the word other. These subcategories are very rarely used, do not count towards diversity, and become an alert in the CLAD report, which the director then has to fix or clear. In general, with few exceptions, don't use the subcategory that begins with other. There is inevitably a more appropriate category or subcategory to select. To continue from the previous slide, the other option can be found in all 4 of the Category 5 subcategories and again is rarely if ever used. Inevitably, there is a more appropriate subcategory to use, or it may be the case that unbundling is occurring and the procedure should be included along with other procedures logged for a particular case. For instance, if you're trying to figure out how to log a tightrope and think if it belongs in one of the other categories, such as 5.4.8, while doing an ankle ORIF, they should all be logged together as a single procedure, and the tightrope should be mentioned in the description. Exceptions to the use of the other categories discussed on the previous slide are subchondroplasties performed in isolation. If they are a part of an index procedure such as those listed here, they can be included in that subcategory. However, again, if they are performed in isolation, the other subcategory can finally be used. Otherwise, their use is quite limited. A few final guidelines include the laterality, left or right, for procedure that must be selected for categories 1 through 5. If work is within an inner space, use R or L 1 through 4. An example is a neuroma excision. The procedure notes section is where additional procedures are to be listed when they cannot be logged separately. Only one first assist for any procedure is allowed, and cases cannot be fragmented to allow for multiple first assist logging. If a case has multiple procedures that follow logging guidelines, first assist can be designated for each procedure. Any reference in this document to midfoot entails any osseous or soft tissue procedure that is performed proximal to but not including the tarsal-metatarsal or Lisfranc joint. Category 1 is for procedures on the toes. This includes the hallux. General guidelines include that procedures performed at the PIPJ and DIPJ can only be logged once, but both procedures need to be documented in the procedure note. Only one resident can log a single first assist and Category 1 procedure for each toe. Again, make sure any additional procedures are documented in the procedure note. Make sure to log the digit number for all digital surgical procedures. You can't perform both the PIPJ and DIPJ arthrodesis, split them between two residents, and give each of them a first assist and digit procedure. This example is a single procedure with a single first assist. The proper logging document does not address every subcategory since many of them are self-explanatory. The proper logging document seeks to clarify those categories which may seem less evident. For instance, the proper logging document addresses 3 of the 13 subcategories for digital surgeries. This is where we start getting into the do's and don'ts of logging. The proper logging document outlines where specific procedures may and may not be logged in conjunction with other procedures. In this case, a phalangeal osteotomy cannot be logged separately if the following subcategories are performed. Since these are all Category 2, which is the first ray category, the guidance revolves around what you can and cannot log in addition to a first ray procedure. As a rule of thumb, the subcategories above each already includes involvement of the proximal phalanx, so an additional digital procedure such as an Aiken is not allowed. However, the above procedures either do not involve the proximal phalanx, so an Aiken would possibly be performed in conjunction, or not indicated, such as a 2.1.9, which may be a Keller, where an Aiken would not be performed. As you progress through the first ray subcategories of valgus, limitus, and other, you see a pattern of when an osteotomy of the digit is appropriate to log separately versus when it is included in the index procedure. If you amputate a toe, you cannot log the procedures above in addition to that amputation. It is all-inclusive that you are managing the infection by performing an IND that includes loss of the toe, so you cannot log them in addition to the toe. If you perform a partial ray amputation, either first or lesser, then you can log that in Category 2 or 4. A panmetatarsal resection or TMA procedure is logged as a single procedure that cannot be separated out into individual ray amputations or resections. Again, you cannot add the procedures of infection management or an IND if you are already amputating the toe. It is inclusive of the index procedure, amputation. When it comes to surgery on the first ray in general, the soft tissue component of all first ray surgery repair is inclusive and not separately claimed as an additional procedure. You log 2.1.1 when all you do is a soft tissue repair with the partial ostectomy. This is only used as long as you did nothing else. Category 2 is limited to 1 per foot, and only one resident can claim first assist per foot. There are 3 subcategories within the first ray category: hallux valgus, hallux limitus, and other first ray surgery. If you perform an Aiken in addition to a first ray procedure, you can use the digital category of osteotomy of the proximal phalanx. The 211 category should be used if you perform repair with the suture and button. If you happen to perform both a head and base procedure on the same ray, category 2, 1, 10 is used. An example would be first tarsometatarsal arthrodesis in addition to a head osteotomy. You do not claim two procedures. All the procedures listed under hallux limited surgery are inclusive encounters one first ray surgery procedure. The remaining subcategories are under other first ray surgery. These first ray subcategories are all inclusive and can only count towards one procedure. These include tendon transfers or lengthening procedures, which can be logged if they are the index procedure and no other first ray surgery is performed. When an amputation of the first ray is performed, either in entirety or partial, no other procedure can be claimed, such as managing infection or IND. Doing so is considered unbundling since the amputation itself is managing the infection and consists of an IND. Management of a bone tumor is used when excision is performed on a neoplasm versus excision of a simple bone cyst. Continuing on with managing infection, again, you cannot log additional procedures at the same time, such as amputation or IND. Specifically, if all you do is amputate the hallux at the level of the MPJ, this does not count as a first ray procedure. Finally, the last category is rarely used, and again, if you're looking to log a procedure where you operate on both ends of the first ray, it is logged as a single case in category 2 using 2, 1, 10. Category 3 is for soft tissue surgery of the foot. It includes excision of ossicles or sesamoids. You only log this category if the procedure was isolated to removing the sesamoid or ossicle. You can't use this category when you also perform and log a first ray surgery or tendon transfer augmentation. You cannot perform a partial first ray procedure, log it as a category 2, and then also log excision of sesamoids in category 3. That is considered unbundling and is not allowed. Also, it cannot be used in addition to Category 4, other osseous foot surgery. Under Category 3, you will find both plantar fasciotomy and plantar fasciectomy. You can log an open, endoscopic, or MIS for plantar fasciotomy. It also includes the heel spur or exostosis resection, as well as the nerve release or ablation. This is not the category to use if TOPAZ or PRP injections are performed and cannot be upgraded to the Category 5 reconstructive rear foot, foot and ankle surgery category. Finally, the fasciotomy category should not be used if a fasciectomy or plantar fibroma resection is performed. When you perform lesser MPJ capsular tendon balancing procedures, use subcategory 3-5. This does not include percutaneous tenotomies or capsulotomies. This subcategory cannot be used in addition to other category 3 procedures such as tendon repairs, lengthening, or transfers in the forefoot, or if you also logged open management of a dislocation. Also, lesser MPJ balancing procedures cannot be used in conjunction with Category 4 procedures, such as arthroplasties, bunionectomies, implants, or metatarsal osteotomies. Tendon repair, lengthening, or transfer in the forefoot cannot be logged in addition to other Category 3 procedures, such as balancing or open management of a dislocation. They also cannot be used if an MPJ arthroplasty is logged. Lastly, these are not percutaneous procedures in this category. Percutaneous tenotomies are logged under Category 6. If you perform open management of a dislocation at the midfoot or MPJ region, there may also be an associated digital surgery that can be logged. However, performing the open management of a dislocation already includes a plantar plate repair or Liz Frank soft tissue repair, so those cannot be logged separately. This is not where a percutaneous procedure is logged. It cannot be logged in addition to other MPJ balancing procedures, tendon procedures, arthroplasties, osseous open management, or fusion procedures. However, it can be used in addition to digit or lesser metatarsal osteotomies. Subcategory 3.8 is I&D wide debridement of soft tissue infection of the foot, ankle, or leg. Generally, this category would only be used by itself. If more than one procedure is selected, it will show up in the CLAD report, so having additional documentation in the procedure note is helpful. That being said, if I&Ds are being performed in distinctly separate areas, they can be logged separately. You cannot log an I&D, amputation, and bone biopsy separately if you can only log one of these procedures. Continuing on with 3.8, it makes sense that if you log an I&D with debridement of soft tissue for infection, you cannot log any of the other subcategories listed here. The I&D is all-inclusive. You certainly can choose any of these other subcategories as your index procedure, but keep in mind that you cannot add an I&D to the logging. Also, please keep in mind that the plantar foot is not included in the reconstructive rear foot ankle surgery category 5. Subcategory 3.4 was plantar fasciotomy. 3.9, plantar fasciectomy. This is not within the category 5 reconstructive rear foot ankle category and does not include TOPAZ or PRP. This is used when radical excision of the plantar fascia occurs for plantar fibromas and is not a simple fasciotomy. 310 is reserved for soft tissue mass excision without reconstruction, such as a ganglion cyst, and does not include verruca or other skin lesion excisions like a 3-1. 312 includes plastic surgery techniques such as skin grafts, plasties, flaps, syndactylization, desyndactylization, and debulking procedures, and is limited to the forefoot. It excludes synthetic and biologic grafts and elliptical or wedge excisions, such as a derotational fifth toe arthroplasty. Procedure note documentation is necessary to ensure proper category selection. If you harvest and apply a skin graft or flap, it is counted as one procedure rather than two. It can be selected in addition to a digital surgery procedure if severe deformity is being addressed. The entirety of the procedure, including wound bed prep or debridement, is all-inclusive and cannot be logged separately. Finally, for Category 3, we have repair, which obviously includes the use of that type of equipment. 3.14 is rarely used. If you're looking to log the harvesting of a graft from any source as an isolated procedure, depending on the location, it would be logged as either soft tissue category 3 or category 5 under reconstructive rear foot. When performing neurolysis or decompression, including tarsal tunnel, use category 316 and only log once, even if multiple sites are involved. Since category 1 is for the digits, 2 is for the first ray, and 5 is for everything proximal to the Liz Frank joint, category 4 involves other osseous, lesser metatarsal procedures with some exceptions. 4.1 is a partial ostectomy of the foot, ankle, or leg, such as Haglund's, retrocalcaneal exostectomy, and ostrigonum resection. A partial ostectomy is not to be used in addition to Category 3, fasciotomy or fasciectomy, or Category 4, bunionectomy, implant, or osteotomy, unless it is on a different metatarsal. 4.2, lesser MPJ arthroplasty, which may be selected when Freiberg's infarction procedure is performed. It is the index procedure and cannot be logged in addition to the other procedures listed here in categories 3, soft tissue, and 4, other osseous. When choosing subcategory 4.4 for methead resection, keep in mind that if you are working on adjoining metatarsals, they are considered one procedure. However, if you are working on non-adjoining metatarsals, they can be counted individually. If you perform a while osteotomy and log it under 4.6, you can also log, if performed, a plantar plate repair under 3.7. 4.8 is used when you perform ORIF of the lesser metatarsals, and each metatarsal can be logged separately. When performing a TMA or any lesser rate partial or total amputation procedure, it is considered one procedure. However, like the ORIF example above, non-adjoining ray amputations can be logged separately. Keep in mind, the amputation not only includes the metatarsal and the toe, but also the IND. Those cannot be logged separately. 411 is typically used by itself and requires documentation if logged with another procedure. If you perform an ORIF at the Lisfranc joint, you would use 413. This includes the first metcuneiform joint, which cannot be logged separately. It is also typically used by itself and cannot include another procedure, such as open management of dislocation or tarsal-metatarsal fusion. Those subcategories can be chosen, but they cannot be logged separately. If you perform a metaductus deformity correction procedure, regardless of the number of osteotomies, it is a single procedure. 415 is used if you perform a fusion at the Lisfranc joint and is considered one procedure regardless of the number of joints worked on. Can be used for acute ORIF or chronic OA, but cannot be used with open management subcategory 3 or 4 and is not to be used for correcting a bunion. 417 is for revision of the forefoot and is typically used as the index procedure requiring documentation in the procedure note if another procedure is logged. 419 is used when the Achilles is detached and reattached after completing an ostectomy. This is generally not used for Haglund's, and neither subcategory 4.1 ostectomy nor 531 tendon repair can be added. Category 5 is for reconstructive rear foot ankle surgery and includes osseous or soft tissue procedures performed proximal to, but not including the Lisfranc joint. Generally, an ankle is an ankle, and that means all procedures in one case are logged as a single procedure, even if they can be logged separately under different circumstances. There are 4 subcategories under the category 5, and they include elective soft tissue, elective osseous, non-elective soft tissue, and non-elective osseous. We begin with elective soft tissue where 511 plastic surgery techniques are logged. This is all inclusive of the wound bed prep, harvesting, and application and does not include simple skin plasty repairs such as ellipses and wedges. Documentation of the details in the procedure note is required. 512 is for tendon transfers with the exception of the plantaris with an Achilles repair, which be logged as 2 procedures and cannot be used in conjunction with soft tissue repair of complex congenital deformity repair, such as clubfoot or vertical talus. This does not include digital tendon transfers such as FDL or Hibbs procedures, which we logged in category 3. 513 is where you would log TALs performed, including percutaneous procedures. This is the only percutaneous procedure that is not logged under Category 6. 515 can be used once per ankle to encompass repair of multiple ligaments and can be used with tendon transfers or augmentation. 516 is used when tendons are augmented or restored and does include excision of the associated ossicle, such as the examples provided here. The repair of both peroneus longus and brevis is counted as one procedure. If you can augment or restore a tendon and transfer it, you cannot log both procedures. You must select the index procedure. If you perform an open synovectomy and use 517, you cannot also log arthroscopy, talar-dorm lesion repair, or an implant. You must select the index procedure only. 521 is for arthroscopy without removal of loose body or osteochondral debridement. If the procedure is purely diagnostic or converted to an open ankle and logged as such, the arthroscopy cannot be logged as well. Other procedures such as stabilization can be claimed as long as it wasn't performed through the scope. Arthrotomy is logged under 528. 524 is selected when a midfoot, rear foot, or ankle fusion is performed to correct a deformity and entails multiple osseous and soft tissue procedures as a single case. There are some examples such as double, triple, or pan-talar arthrodesis. If an osteotomy is performed in addition to the arthrodesis, other subcategories can also be claimed. 525 is selected when an osteotomy is performed. However, if that osteotomy was performed to access the index pathology, then it cannot be logged separately. An example is a fibular osteotomy to create an on-leg graft for access to the ankle joint. There are other procedures that can be claimed if the osteotomy was part of deformity correction, and multiple osteotomies can be claimed if correcting a deformity such as Evans and Cotton or Evans and calcaneal slide. 526 is for resection of coalitions and is typically a standalone index procedure. If it is part of an arthrodesis or if an arthroresis was performed, it cannot be used. However, if an arthrodesis or osteotomy is performed to correct a deformity not located at the coalition site, then it can be logged separately. If you perform open management of talar dome lesions, it includes the arthroscopy if that's what you started with, but not a subtalar joint arthroscopy. You can't log managing talar dome lesions in addition to an ankle fusion, malleolar osteotomies, ankle implants, or procedures like subchondroplasties. If you perform an arthrotomy or arthroscopy with removal of loose bodies or osteochondral debridement, you can't also log an ankle fusion, malleolar osteotomies, implants, or subchondroplasty. When performing an ankle implant and logging 529, it encompasses every aspect of the procedure and cannot be logged in conjunction with other rear foot procedures. When selecting 532, repair of acute ligament injury, You cannot log other obvious procedures. When you do ORAF, they include all the soft tissue repair necessary to address the trauma. And as we just discussed when performing an ankle implant, nothing else can be logged. Also, no matter how many ligaments you repair, it is considered one procedure. If 534 is logged for excising a tumor with an associated reconstructive element, the harvesting and application of the graft is one procedure. If you perform an open repair of a dislocation and log 536, you cannot also log open repair of the fracture or repair of the ligament. It is one procedure per foot or ankle. The final subcategories in Category 5 are related to open repair of adult or pediatric fractures. You can only claim one procedure regardless of the amount of work per foot or ankle. Category 6 is for all the other podiatric procedures that are frequently performed. The examples on this slide include treatment of verruca, skin lesions, nail avulsions, hardware removal, including X-fixes, laceration repair, extracorporeal shockwave therapy, and experiences in taping, padding, splinting, casting, orthotics, and prosthetics. The remaining Category 6 procedures include percutaneous procedures, PRP, primary care, injections, simple INDs, closed reductions, simple foreign body removals, and application of any X-Fix device. Category 7 is for biomechanical exams. To meet the requirement, there must be a complaint that aligns with the evaluation, include a gait analysis, and have an associated diagnosis and treatment geared towards conservative management. There must be recognition of the underlying biomechanical pathology and documentation of direct treatment considerations other than surgery. Category 8.1 is for the comprehensive H&P and must fully encapsulate the components of a full exam. There are many minimum of 50 required within at least 25 being completed under non-podiatric supervision. They can be performed in a number of different settings but must include all aspects of a comprehensive exam. There is also an 8.2 for problem-focused H&Ps, which can be used to document encounters which do not have all the components of a comprehensive history and physical exam. It is required that residents log rotation experiences above and beyond podiatric surgical and non-surgical cases. Part 1 of logging guidance introduced everyone to options within PRR for every rotation. There should be documented evidence of growth during residency training with no gaps and continuance beyond just meeting the MAVs. Some programs interested in growing their resident complement will rely on logged experiences to provide evidence of ability to support additional trainees. Prior to graduation, make sure you save a copy and print out for your future needs. Your account will not always be available after you leave the program. Please pass on good logging habits to your colleagues and be aware of the resources on the CPME and PRR websites. To avoid confusion when double scrubbing, add a logging discussion to each case. Review how everyone is logging and take the opportunity to provide instruction and mentorship during case review and whenever possible, find or become a mentor. Thank you, and I hope you found the information within this presentation helpful. If you enjoyed these, please watch for release of a third presentation in the series, which would entail more detail on the step-by-step processes of logging in PRR for residents and verifying for directors in addition to utilizing other PRR functions.